seconds. Good.
Looks like
Looks like it's recording.
Okay.
There you go. Thank you.
All right. I guess we'll go ahead and get started because I don't want to extend over too much on time. I gave grand rounds actually yesterday for allergy and immunology, so we went over a little bit then. The clock was like behind me, so I couldn't tell. Maybe I should get my... So I actually didn't come from SLU today. I came straight from my house, which is in Kirkwood, so it was actually sort of on the way with a little detour. So as was said, I am in the Department of Dermatology, so I see patients 2 days a week, and then I also do dermatopathology, so reading the biopsy slides the other part of my time. I'm also the residency program director for dermatology too, and I run the contact dermatitis and patch testing service. So I've seen, some OB-GYN patients for, vulvar pruritus and dermatitis, question allergic contact, and done some patch testing for some of your faculty. All right, so we'll go ahead and get started. I've been asked, and I've done this for several years now, to do part of the curriculum that's required for the MFM fellowship, Dermatologic Changes and Disorders of Pregnancy. So I was provided the updated guide. The last one I had was from 2007, but there is a new one available, 2013. And so these are the things that you're required to know when you do your MFM training. Most of these were similar from 2007. The only thing I believe that was added was the papular dermatitis of pregnancy was added as a specific diagnosis. I've always included that in my talk, but it is specifically mentioned here in what you all are supposed to know. So first we'll start with the common changes of pregnancy related to the skin. And most of these are going to be things that you guys see every day, so it's not going to be, earth-shattering information, but, just more specific, make sure that you're actually noticing that these are the changes that you see with pregnancy. So pigmentation can change in several ways. It's probably related to increased estrogen, possibly progesterone, and melanocyte-stimulating hormone. The places that tend to become hyperpigmented are the nipples, areola, external genitalia, and the linea alba, which becomes the linea nigra, which obviously is being shown here. It's very common, and it usually does, at least partially, and usually completely regress after pregnancy. Another area where pigmentation occurs that women get quite concerned about is on the face, and this is called melasma. You get this blotchy pigmentation. This is a pretty extreme example. Most people aren't quite that pronounced, but for picture's sake, it's nice to get the most elaborate example. So this occurs commonly to about 70% of women. It is worsened by sun exposure. So basically when I see somebody in my clinic with melasma, the first thing I tell them is you need to be really good about your sun protection. In dermatology, we kind of think about two different types of melasma, dermal type or epidermal type. And when you use our Woods lamp, nickel oxide filter lamp, the epidermal type enhances, so it becomes more pronounced or more dark when you look at it, whereas the dermal type is not enhanced. It's thought that probably the epidermal type is easier to treat because we can use some of our, kind of exfoliating substances and bleaching creams to target that pigment. Once it's deeper down, it's harder for those topical medications to work. This does tend to regress after pregnancy. However, it can definitely persist, and especially if someone's going on oral contraceptive pills, we see that it can persist, and even when somebody hasn't had it during pregnancy, they can present when they go on to oral contraceptive pills. So the treatment, as I mentioned, sun protection is huge, and then you can do hydroquinone or tretinoin. Obviously, during pregnancy, you probably wouldn't want to do that, and knowing that it will at least partially regress after pregnancy, it's probably best to just, hold off on any aggressive treatment and just sun protection. And not just sunscreens, but hats, things like that can also be, quite protective. So moving on away from pigmentation, so there are some changes in the hair and nails. There can be some hirsutism or abnormal hair growth. I call it abnormal, but it's actually normal in pregnancy. It also resolves after delivery. Telogen effluvium, really common, about 1 to 5 months after delivery. They lose some of their hair. It's said that it's never more than 50%, but if someone loses 50% of their hair, they're going to be pretty freaked out. So, but it does grow back, and, there's a lot of hand holding involved, and, just kind of explaining that stressful situations, whether physically or emotionally, can cause this. I typically don't see people that are losing 50% of their hair, but, it can be, it's pretty obvious, they're losing it in their brush or in the shower, and they get very upset about it. Nails can be brittle. However, sometimes when you're taking prenatal vitamins, it actually can kind of make the nails stronger. So there's no scientific evidence of that, but just kind of anecdotally. And this is just a picture of the hairbrush with all the telogen effluvium hairs. And then in dermatology clinic, not so much when someone says they've had a baby 3 months ago and they're starting to lose their hair. I mean, that's pretty obvious. That's telogen effluvium. But we'll see patients, that just come in with hair loss. We'll do a hair pull. Basically, we'll just run our hands gently through the hair about 3 or 4 times and see if we can extract some hairs. We don't yank them out. We're just gently pulling. And this is a telogen hair. It's a club hair is another name for it. And it's not like a golf club. It's like a billy club. So that's why it's, kind of more of a blunt end. So when you do the hair pull, if you get 5 or 6 hairs and they're all in telogen phase, then you're kind of thinking that it is telogen effluvium. Again, I don't typically do that for someone that's immediately postpartum. That's pretty obvious that's what's going on, but I like pictures, so I put it in there. Some other changes related to connective tissue. So the striae, stretch marks. Everybody wants to know how to prevent them, and unfortunately I tell them there's no way to prevent them. So it's oftentimes genetic, related to kind of the connective tissue that they inherited from their parents. So we know the common places they get them, typically during the 6th to 7th months. However, that is variable, and people can get their first stretch mark the day before delivery, and that's pretty stressful too. So they are pink purple at first, then become pale, and treatment, tretinoin, laser, again, you don't want to treat these during pregnancy, but afterwards. And they are more easily treated during that pink or erythematous phase. Unfortunately, that isn't when people usually come in. It's when they're in the pale phase, and there's not a whole lot you can do for them at that point. So the reason is that in the pink phase, just the laser is more of a target towards vascular structures, and that's kind of what you're targeting there, and so is the tretinoin.
Do people ever have the erythematous phase postpartum?
Yeah, they typically will still be pink at postpartum, yeah. But they just, they're busy. They're not coming into the dermatologist until, they're white. And it's variable how long they can stay pink, so, if they're really concerned. What?
Why can't you laser during pregnancy?
I avoid doing any procedures during pregnancy just because of any medical legal implications. So, and I actually I'm not a cosmetic dermatologist. We have 2 cosmetic dermatologists. I would suspect that they would not do laser either during pregnancy, but I think it's just the fear of if anything goes wrong, you don't want to be,
Blastose goes right into the uterus, and lasers all over the place.
Yeah.
Right by the fetus.
I don't think there's any true risk to it. It's just, if you're I guess doing a cosmetic procedure of any type during pregnancy, if there's any ramification of that. I'm just always afraid of being up on, this witness stand or something. So, but yeah, I don't actually do laser treatments, but I've never heard our cosmetic dermatologist talking about treating them during the actual pregnancy.
Is laser efficacious in African American patients, or is that is there natural skin tone to make that hardly feasible? Because I know some laser.
Yeah, you know, they still will have a pinkness to their striae early on. It's harder to see. It's kind of the same with all of our skin diseases. In darker skin types, the pinkness is hard to see, but it is there. So I do think that it could still be an option. So the skin tags at the neck and axilla, they have a special name in pregnancy, molluscum fibrosum gravidarum. Not to be confused with molluscum contagiosum, which is the viral, illness. It's causes little flesh-colored papules. The reason all of these have these names like this is because they were based on the clinical presentation, not like what they actually are caused by. These tend to regress after pregnancy. I do have a lot of pregnant women come in very distraught about their skin tags, and I basically tell them they are going to mostly go away after pregnancy, because the reason I do that is because we charge a cosmetic fee for skin tag removal, and I'm like, do you really want to pay $137 now, or do you want to see which ones come off on their own after you deliver? And most women will opt to just wait to see which ones regress. So that's not, I would be fine snipping a skin tag during pregnancy, but most people, when they hear most of them are going to go away, they're just like, okay, never mind. So this is just an example of striae. This is the erythematous phase here. These are pretty pronounced. And then the more pale phase. Some vascular changes during pregnancy. So the palms can get red, the gums can get red, and there's just a lot more blood flow there. They can bleed more easily, the gingiva, spider angiomas, which we'll see a picture of those appear in the 2nd to 5th month. I usually see them in the upper part of the body, the face and the upper chest area. Non-pitting edema happens, as you all know, vasomotor instability, so they can more easily flush or get cutis marmorata, which I'll show a picture of that as well. Varicosities, hemorrhoids, pyogenic granulomas, those are those friable, like vascular tumors or lesions that you can get more of those during pregnancy, especially within the mouth. Those also have a special name in pregnancy, granuloma gravidarum or pregnancy epilis. Again, they're not really granulomas, they're more of a vascular lesion, and common in kids as well. This is thought to be from vascular distension and instability, as well as new vessel formation. And similar to all of the things we've talked about, they do tend to regress after delivery. So some of the things I mentioned, so this sort of mottled erythema of the lower extremities, that is the cutis marmorata. Again, that is considered a normal change of pregnancy. Spider angiomas, these little, and they kind of seem like they wouldn't regress because they actually often have like a papule or a raised area in the middle, and then these little spiders coming out, but they often do regress. If they don't regress, you can again do pulse dye laser for those to get rid of them, but you don't want to have to charge somebody $400 for something that is probably going to go away on its own. Granuloma gravidarum, that's that pyogenic granuloma within the mouth here. These you may need to treat during pregnancy because they can easily bleed, and trying to eat with something bleeding in your mouth is not exactly ideal. So these you may end up having to send to the dermatologist to treat.
What do you do?
What we usually do is we'll do a shave biopsy to get rid of the bulk of the lesion, and also to confirm the diagnosis, because that way we have tissue to send off to be looked at under the microscope. And then we'll bifurcate the base. So we'll just kind of burn the base of the biopsy site.
On the marmorata, was this similar appearance that the white reticularis that was reported with antiphospholipids?
Yes.
How would you differentiate it just by?
Well, if it just appeared during pregnancy, you would, I guess, assume that it was just related to the normal changes of pregnancy. Because antiphospholipid antibody syndrome, in my in my experience, wouldn't just, present during pregnancy. If it persisted after pregnancy and was this pronounced, then you would probably need to have a workup for some kind of a coagulation defect. So the other thing is, you can get cutis marmorata when somebody's cold too, if it persists, even when somebody's warmed up and that type of thing. But, uh-oh.
Just hit resume, looking back smack in the middle.
Is that good enough? So there are some skin diseases that are affected by pregnancy. And the inflammatory dermatoses that can be affected, atopic dermatitis, so, one of the things that we see day in and day out in dermatology. Pregnancy actually usually worsens this. It is the most common dermatosis of pregnancy, so people will come in and either have never had a history of eczema or atopic dermatitis or have a history, but now it's a lot worse during pregnancy. It's thought that during pregnancy you're switching more to a Th2 T helper cell response, and then that is sort of pushing your atopic dermatitis to be more active. So typically, just explaining to patients this is something that can happen during pregnancy and treating them with appropriate strength topical steroids. Psoriasis actually usually improves, possibly because of IL-10's involvement in pregnancy, although later on we're going to hear about a specific type of psoriasis that can present in pregnancy. Connective tissue disorders, Ehlers-Danlos, people with types 1 or 4 are more likely to have problems. They can have rupture of vessels, poor wound healing, uterine laceration, uterine or bladder prolapse, and abdominal hernia. Patients with pseudoxanthoma elasticum, GI bleeding can be a complication during pregnancy.
Dr. Burkemper, can we make a diagnosis of psoriasis in pregnancy if you have the classic symptoms?
Sure.
Can we?
Mm-hmm.
Or do we need to send them to you?
It's whatever your comfort level is. So I'm going to show a picture of psoriasis so we can kind of talk about what it looks like. This is not psoriasis. This is atopic dermatitis. So these are the popliteal fossa, and these are lichenified pink plaques. So lichenification means that there are exaggerated skin markings here, basically from the chronicity of the condition, constant scratching. So the typical places that atopic dermatitis presents are on the flexural areas, so where you bend. So the antecubital fossa, the popliteal fossa, we'll sometimes see it on the breasts as well, and the nipples, and so that's kind of the classic presentation of atopic dermatitis. As compared to psoriasis, which is usually more extensor, so where you extend. So knees, elbows, the back of the scalp is a really classic place for psoriasis to present, the external ear canals, the umbilicus as well, and as compared to atopic dermatitis, you can't exactly tell where the lesion starts and stops. It sort of fades into the background, as opposed to psoriasis, where the edges of the plaques are very well demarcated. That's a pretty classic presentation. The overlying scale of psoriasis also tends to have a more silvery look and a more adherent kind of look. If you are able to pick off some of the scale, you get this little pinpoint bleeding of the skin. It's called Auspitz sign. So all of those things could, lead you to a diagnosis of psoriasis. The good thing is that both atopic dermatitis and psoriasis are both treated with topical steroids sort of as the first line. So, even if you're not sure which one it is, you could kind of treat it and see what happens. But the important thing with psoriasis is the arthritis that could be associated with it. So if you're at all suspicious about, psoriatic arthritis, that should be more thoroughly evaluated for, because it does have the potential to be a destructive arthritis, and so you want patients to be on appropriate treatment for that. So. Some other skin diseases that are affected by pregnancy, systemic lupus erythematosus. During pregnancy, they can get cutaneous flares, especially a painful vasculitis on their extremities, which is what's being shown in this picture here. They do have an increased risk of spontaneous abortion, and neonatal lupus, which is being shown here, these little annular plaques on this little baby's face. It usually is in areas like on the face and scalp, because it's kind of more sun-exposed areas, although newborns aren't typically being exposed to the sun that much. Just any amount of sun exposure can kind of trigger that neonatal lupus. So those are in patients or the mothers that have SSA antibodies, and the real risk of neonatal lupus is the congenital heart block that they can have. Dermatomyositis also can be affected by pregnancy. They can have a flare of their rash. That heliotrope rash is the rash around their eyes. It's like a purple rash, as well as their muscle weakness. Spontaneous abortion, stillbirth, and neonatal death due to immaturity can occur in a pretty good proportion of patients. So kind of switching gears a little bit, this is a cutaneous disease that can occur during pregnancy, so that's why it's kind of in this category. So nevi and melanoma. So moles in and of themselves can appear somewhat larger during pregnancy, just depending on where they're located on the body. So if it's a place that's expanding during pregnancy, the mole can expand as well. However, it shouldn't be expanding out of proportion to the enlargement of that part of the body. And if it's in a place like an arm or something that's not really enlarging and it's starting to grow, then you need to be concerned. There can also be a slight darkening because of those hormonal changes that I mentioned earlier. However, anything out of that sort of slight change should be investigated appropriately with a biopsy, whether you're doing that in your office or sending them to dermatology. Basically, for any changing mole, we will get somebody in within a day or two. So if you are concerned that something is a melanoma, have your office staff call, or the patient can call and say, I have a changing mole. My, obstetrician is very concerned about it, and we'll get them in within a day or two to evaluate it. There's no convincing evidence that there's an increased incidence of melanoma during pregnancy or a decreased 5-year survival in melanoma diagnosed during pregnancy. Evaluation and treatment of advanced melanoma means that early delivery may be necessary depending on how far along they are and how advanced the melanoma is. It's also suggested, and this is always a case-by-case basis, but in a woman diagnosed with a high-risk melanoma, meaning a stage 3 or 4, so lymph node or distant involvement, waiting 2 years before pregnancy, 2/3 of recurrences develop in this time frame. So you want to, be cognizant of that and kind of think about the risks of the future. This is something that's put out by a group from Yale, that this is sort of their protocol for how they will kind of deal with melanoma diagnosed during pregnancy. So a stage T1A, this is a very superficial melanoma. There are no mitotic figures, there's no ulceration. So this is a very low risk primary, and sentinel lymph node is not indicated whether you're pregnant or not pregnant. So you basically will do wide excision with local anesthesia. You won't delay it till, after delivery or anything like that. So the tumor stage 1B or greater, this would be a significant risk, and sentinel lymph node would typically be indicated for anybody. So stage T1B means that it's usually more superficial, meaning it doesn't go super deep into the dermis, but there are some other high-risk features such as mitotic figures or ulceration. And then it says or greater, so basically, when you start getting deeper into the dermis, those types of things, all of those would be higher risk melanomas. So if the patient is in their first or second trimester or early third trimester, so basically a time when you wouldn't necessarily want to do early delivery, if they have a stage T1B or T2, so these would be the a little less significant risk, you would do immediate wide local excision under local anesthesia and then postpartum sentinel lymph node biopsy. Now this is only the opinion of this group from Yale, so I'm not going to say that this is what would happen anywhere you went, but I'm just saying this is kind of what's out there, and it is a little bit controversial, and nobody has a cut and dried way to treat it. So stage T3 or T4, these are very deep melanomas with a lot of high-risk indicators. So this would actually call for immediate wide excision and sentinel lymph node under local anesthesia. So sentinel lymph node does require some exposure to radiation, so that's one of the concerns about sentinel lymph node during pregnancy, and that's why in these lesser significant risk ones, they sort of wait to do the sentinel lymph node till postpartum. If the sentinel lymph node is positive, then they typically would do completion lymphadenectomy under general anesthesia. You can't really do a complete lymph node dissection under local anesthesia, I don't think. If the patient's in the late third trimester when they're diagnosed with a high-risk melanoma, basically early delivery would be indicated with postpartum wide excision sentinel lymph node under general anesthesia. And then they do have this category if a melanoma is diagnosed during pregnancy, termination of pregnancy, but they say not recommended by their group. So we tend to send our high-risk melanomas to Dr. Shea in general surgery, and he's, very good about discussing the different approaches and things. I don't know that I've actually heard how he deals with this kind of group of patients here in the pregnancy group, but I might actually ask him that in the future. So this is just a picture of a pretty obvious melanoma. I put this up here because it basically has all the features that you would look for a melanoma. So if you see a lesion that has, any of these features, or at least, a couple of these features, you would want to be concerned. So first of all, it looks like it's quite large. I think this is like the axilla here, so you can see this is quite a large patch on somebody. It has very irregular borders. The borders are kind of jaggedy. It's asymmetric. One side doesn't look like the other side. It has lots of different colors in it. This is not a normal mole. So it's got black, it's got brown, it's got pink, it's got white, which often means regression, meaning there was melanoma there and now an inflammatory response has come in and kind of gotten rid of parts of it. It also has kind of an area that looks kind of milky white. That's also a worrisome kind of color to a pigmented lesion. The diameter, as I mentioned, looks like it's quite large, and if you ask the patient, I'm guessing they would tell you it's been changing. So those are the ABCDEs of melanoma. So A is asymmetry, B is border, C is color, D is diameter, and E is evolution. So moving on to the well-defined dermatoses of pregnancy. So again, these are from that list of things that you guys are supposed to know for your MFM training. So pemphigoid, or what used to be called herpes gestationis. This is a bullous dermatosis, so a blistering rash of pregnancy and the immediate postpartum period. It tends to be quite itchy. It is rare, fortunately, so only 1 in 50,000 pregnancies. It usually occurs kind of in the middle of pregnancy, so fourth to seventh month. It's caused by an IgG antibody called the Hg factor against a portion of the BP180 antigen, so that's the bullous pemphigoid 180 antigen, so it's the same antigen as bullous pemphigoid that we see kind of in the older patient population. The antibodies may initially be produced to disparate HLA antigens, possibly on the placenta, and then cross-react with the skin, but the exact mechanism of this is unclear at this point. So this is a little schematic showing the basement membrane zone of the epidermis dermal interface. So this is a keratinocyte up here, and this is the dermis down here. And then there is a structure called the hemidesmosome at the base of the basilar keratinocytes that basically hold it to the dermis. And then there are these proteins that extend from the basilar keratinocytes into the upper portion of the dermis. And the one here, the BP antigen 2, is the one that's targeted in pemphigoid gestationis. So there's an antibody that's targeting this protein and basically making it dysfunctional. So it's not anchoring the basilar keratinocytes to the dermis any longer. So it presents with these very itchy pink papules or raised bumps and plaques, which are like the larger papules, often with vesicles or bullae, usually involving the abdomen umbilicus, spares the mucous membranes, flares in the postpartum period, remits within a few weeks. It may or may not recur with subsequent pregnancies, menses, or OCPs. The classic thing to remember is that pemphigoid gestationis does often involve the umbilicus as opposed to PUP, which tends to not involve the umbilicus. So that's something that you maybe ask on like a board question or something like that. So this is a darker patient with these very kind of edematous pink plaques involving the umbilicus as well as the surrounding areas. This patient doesn't seem to have much in the way of blisters. However, we're going to see some that do. Proximal extremity involvement, you can see again those kind of edematous or swollen pink plaques here, but then you can start to appreciate that there are some vesicles at the top, clear-filled blisters, and then larger ones which are called bullae. These are not infectious at all, they're sterile. So you may be concerned that they're infectious, and it's always worthwhile to do cultures if you're suspicious of something else like, you know, a herpes infection or something like that. This is a more pronounced example, obviously, with some pretty extensive bullae formation on this patient. And then just a closer up look. Again, you can appreciate a little bit of that background erythema and then the bullae. So if you biopsy this, and basically you do need to biopsy it to make the diagnosis, in my opinion, you'll see a subepidermal vesicle with eosinophils, and I'll show a picture of that. And then in dermatology, when you send the patients for evaluation, we often will also do a direct immunofluorescence biopsy. And this is done with a special staining technique, and we will find this linear basement membrane zone staining with C3 much greater than IgG. So we look at different conjugates and the antibodies that are depositing in the skin, and that's how we make this specific diagnosis. PUP would have negative direct immunofluorescence results. Pemphigoid gestationis would have positive ones. There's also a blood test that you can order. There's an ELISA stain, the BP180NC16A ELISA, that you can order on the patient's blood. So this is a picture of what we would see under the microscope just with regular histology. So this is the epidermis up here and the dermis down here, and just like that little cartoon I showed, you know, that basilar keratinocyte is being lifted off the dermis, so you're getting this cleft here. And then if you look closer within that cleft, you can see these inflammatory cells, and many of these are eosinophils. This would look exactly the same under the microscope as bullous pemphigoid in an elderly patient. So, and then this is the direct immunofluorescence. So it's a little harder to see because it's dark, because we use that, we have to do that to see the fluorescence. But the epidermis would be up here, and this is the dermis down here, and then this is that basement membrane zone, and it's staining very strongly with C3. So that would be a positive direct immunofluorescence. We typically would treat this with systemic steroids. There is an increased risk of prematurity in small for gestational age infants. Newborns can be affected about 10% of the time, usually mild and resolves within 2 to 3 weeks, so usually don't have to treat them very aggressively. So Prudic urticarial papules and plaques of pregnancy, or PUP. I just want you to know that it also goes by a different name now, polymorphic eruption of pregnancy. I know at least on our board exams, they always like to give you the alternate names to kind of trip you up, and you're like, I've never heard of this before, but just remember that that is the same thing as PUP. This, as opposed to pemphigoid gestationis, is quite common, 1 in 130 to 300 pregnancies. It is intensely itchy, usually late in the 3rd trimester or immediately postpartum, which is really advantageous to us because we usually don't have to treat it very aggressively because they're about to deliver, you know, next week or something. Typically with primigravidas, twin and triplet pregnancies, and obese women, it's thought to possibly be related to weight gain during pregnancy, but we don't have a real good handle on why exactly it happens. These start out as pink papules on the abdomen, and as I mentioned, they kind of spare the umbilicus, and they can spread to the buttocks and thighs. And I had already mentioned the direct immunofluorescence will be negative. So, you know, this doesn't present with blisters. However, pemphigoid gestationis in the beginning phases doesn't either. You usually can tell one versus the other timing-wise and just what it looks like. But, you know, if I see a patient in my clinic and I'm not sure, I'll, you know, just biopsy it to make sure. So this is an example of PUP. You can see the sparing of the umbilicus here. So just pink papules within the striae on the abdomen. And the patient will say they're very itchy. You can almost appreciate that that would be pretty itchy, right? Another kind of more subtle example with smaller papules on the abdomen. This one's extending onto the arms as well. This is harmless to the fetus and mother, except just, they're probably awake at night because they are so itchy. Triamcinolone 0.1% ointment is kind of a good topical steroid to use. If it is severe, you can do systemic steroids. I really avoid that in PUP if at all possible, and typically the topicals will be okay.
Question: why does it spare the umbilicus? Why?
I don't know. I have no idea. It's just so it can be a good boards question, maybe. I don't know. If we knew the exact etiology, maybe we could explain it, but I really don't know. Maybe it's because the connective tissue is different in that right at the umbilicus. I don't know. It does resolve spontaneously just a few days after delivery, and it doesn't tend to recur with subsequent pregnancies. Yeah?
Are atopic individuals more prone to?
I have not seen that atopic patients are more prone to it. Have you noticed that, or?
A large series.
A lot, yeah. I mean, I'm just basing this on who I see in clinic. I would say that most of the patients that come in, they'll say that they've never had a problem with their skin before. So just from what I see, it doesn't tend to be more pronounced in atopics, no. Now, atopic patients will come in with an itchy rash, but it's usually just their atopic dermatitis that's flaring up during their pregnancy. But yeah, I don't see an association with PUP too much. So, oops. Yeah. So, intrahepatic cholestasis of pregnancy. So, this actually doesn't tend to have a rash. It's more itching, but it is a condition of the liver occurring in late pregnancy. And as I mentioned, they just have a really bad generalized pruritus. It's because their bile acids are not being secreted properly. You can divide the patients up into those that actually have hyperbilirubinemia, and those are called cholestatic jaundice of pregnancy, and those without hyperbilirubinemia, and that's prurigo gravidarum. The pruritus may precede the jaundice by 4 weeks, so it's important to recognize that something may be going on so that you can diagnose it early. And there may be a genetic predisposition related to this multi-drug resistance gene 3. I don't know if that shows up in any boards questions or not, but third trimester is typical. As I mentioned, there's not a primary rash, but excoriations are common. So if we see a pregnant lady that comes in and is very itchy but no primary skin lesions, we'll often do some workup of the liver. May have other systemic symptoms such as fatigue, anorexia, nausea, and vomiting, dark urine, light stools, and then on lab tests, you can find transaminitis, total serum bile acid salt elevation, and plus or minus bilirubin. You do kind of need to specifically order the bile acid salts to kind of evaluate for that. And this is just a picture of excoriations on a patient with this condition. So the reason it's important to diagnose this is that malabsorption of fat because of this bile acid dysfunction can lead to vitamin K deficiency. There's a risk of postpartum hemorrhage and fetal intracranial hemorrhage. This usually remits after delivery, but it can recur in subsequent pregnancies, and there is a significant risk to the fetus, so fetal distress, stillbirth, and maturity. So if you do identify it, you do want to treat it. Obviously, you want to treat the pruritus, but more importantly, you want to treat the bile acid dysfunction with cholestyramine, ursodeoxycholic acid. Ultraviolet B can help with the jaundice and also the pruritus. Sequential non-stress tests, biophysical profiles, and then you may need to do some intramuscular vitamin K to decrease the risk of hemorrhage. So I kind of alluded to this earlier. So impetigo herpetiformis is a special form of pustular psoriasis that occurs during pregnancy. The name is unfortunate because it is neither impetigo or herpes. But the reason it's called this is because the pustules tend to be grouped, so that's where it gets kind of the herpes type name. And then the impetigo, I guess somebody at some point thought it looked like, a bacterial skin infection or something. It can be life-threatening, occurs typically in the third trimester, and many actually have no personal or family history of psoriasis, so it's kind of a spontaneous occurrence. We do have forms of pustular psoriasis that happen not in pregnancy too, but and those tend to not be so harmful, but the one during pregnancy tends to be the one that we worry about the most. So typically begins as non-itchy pink patches, and then they're studded with these little superficial pustules. So I don't know, actually I have pointers. I don't think the pinkness is coming through very well here, but you can see these little tiny pustules here. So this is kind of the very earliest lesion of impetigo herpetiformis. The kind of flexural areas tend to be involved first. That's true with a lot of our pustular diseases, actually. I don't know why, if friction has something to do with, why the pustules form in those areas. And then they often will have systemic symptoms as well. It is associated with hypocalcemia. There is a risk of bacterial sepsis, not because the condition is infectious, but because these lakes of pus, as we call them, you can see this is a more advanced condition here with the little pustules, but they're coalescing into these lakes of pus, and they can get secondarily infected, and so that's why the bacterial sepsis can occur. It does tend to remit after pregnancy, but it can recur. There is a risk of fetal morbidity and mortality because of placental insufficiency. That can occur even with treatment. So the treatment, this is difficult because what we often will treat pustular psoriasis with in general may not be safe in pregnancy. Systemic steroids, they've been around a long time. There's a lot of experience with them. You guys use them to, mature the fetal lungs and things like that, would be considered maybe first line. Other things in recalcitrant situations would be cyclosporin. There are some reports of that. And then a few isolated reports of the literature of doing anti-TNF agents, specifically Remicade or infliximab is the generic name for that, because it's fast acting. It'll, be effective within a couple of weeks. So, and then treating any underlying infections, obviously, and any hypocalcemia. So the poorly defined eruptions associated with pregnancy, I have about 12 minutes left. So the prurigo of pregnancy diagnosis, or prurigo gestationis, encompasses a lot of different names that have been used in the past. Many of them have names of people on them. Everybody wants their name on something. Besnier's prurigo gestationis, nurse's early prurigo of pregnancy, and papular dermatitis of Spangler. So I believe in your list of diagnoses, it's called papular dermatitis, so but all of these names can be used to describe the same thing. This can occur in about 1 in 300 pregnancies, can occur at all trimesters. Papules and nodules on the extensor surfaces of the extremities and abdomen that can become excoriated and encrusted. Last weeks to months postpartum. Serologic tests are normal, so as I said, if you have somebody coming in with a complaint of pruritus, you should check, liver function. I do think that this is related to atopy. I think that, this is probably a form fruste of, eczema and atopic dermatitis. They're just maybe not presenting with the classical lichenified plaques of atopic dermatitis. So topical steroids plus or minus antihistamines to help with their itch. So this is an example of that. Pruritic folliculitis of pregnancy, or PFP, often misdiagnosed as bacterial folliculitis because the lesions are quite follicular, so follicularly based, and can have little pustules. The way you can tell if it's bacterial is you can do a little culture, and if it's negative, it's probably not bacterial. Can develop later on in pregnancy, may be a form of acne. You can use topical steroids. I don't know if I've ever seen this condition, but if I have, I probably didn't do a whole lot for it. Topical steroids because it can be itchy. Benzoyl peroxide, this is a pregnancy category C, so I tend not to recommend it specifically, but it is said to be a treatment for it. And then the ultraviolet B light you could do if the patient is really, really itchy, but I typically wouldn't think that it needed that. Oh, really?
And face from it? Because it's just like acne.
Yeah.
It's itchy.
Huh.
And it's face and a little bit on the chest.
I was going to say, I usually think of this as more trunk, but I'd be happy to see her. Yeah, sure.
And then you talked about sending a culture, how do you send a culture on one of these? I mean, you just
So the bacterial culturettes, I guess, do you guys have blue top tubes for those as well? Do you guys have bacterial culturettes in your clinic? So if there's a pustule, I typically will nick the top of the pustule open with a blade. I like to use an 11 blade. If you guys don't have those in your clinic, you can do any little blade, nick it open, and then the pus that comes out, you just swab it with the bacterial swab and send it off for aerobic bacterial culture. If you try to send a cutaneous swab for anaerobic, they'll tell you that's inappropriate. So aerobic bacterial culture. It's very easy. If there's no pustule, you can just, if there's an excoriation or a crusted lesion, you can just swab kind of aggressively over the crust. So this is an example. Like I said, I usually think of it more on the trunk, so I mean, I'm not saying that it couldn't be, but it sounds like it should be interesting to see anyway. So,
It's her face.
yeah.
It's mainly almost forehead. It's like a distribution of acne.
Yeah.
It's the distribution of acne.
But it's itchy. Okay. Well, I'll give you my card. So autoimmune progesterone dermatitis, this isn't really a specific dermatosis of pregnancy, but it can occur during pregnancy. You get the cyclic flare of dermatitis that typically responds to the luteal phase of the menstrual cycle when the progesterone levels increase. And this can present in a variety of clinical manifestations, pink scaly patches, urticarial wheals, basically hives, papullovesicles, and even targetoid lesions. So when you think of targetoid lesions, you think of erythema multiforme, but this is not erythema multiforme. They can have pruritus or oral erosions as well. So how you diagnose it, you would inject intradermally progesterone, and they develop urticaria or erythematous induration at the site of injection. And the treatment for this is you inhibit ovulation with conjugated estrogen or oophorectomy in intractable cases. Again, you wouldn't be doing these things during pregnancy, but it is uncommon for this to present during pregnancy, but it can present during pregnancy, so that's why I'm bringing it up. And this is a patient with that, with maybe the more kind of hive-like urticarial plaques on their lower back. This is really uncommon. I've only seen a couple of cases of it, but I just thought I'd bring it up.
We had a patient once whose husband was a germ resident too.
With it? So if anybody has any more questions, I think I was told I was supposed to provide 10 minutes, 6 minutes. Thank you. And if you, I can give you the number for the dermatology clinic if anybody does have a patient they need to get in to see us. 314-256-3400. I'll repeat it again. Intentionally, I said it really quick so that 256-3400. That's for the ABI clinic. We also have a clinic at DePere too. If your patient prefers to go to DePere, I don't know if I have that number off the top of my head, but if you called that 3400. If you called that number and you said you needed the number for DePere, they could definitely provide that for you. But since I don't see patients out there, I don't have that one on the tip of my tongue.
Do you want to see my lady specifically?
Sure.
Yeah. Last name is Jones. And she's pretty much that's the weirdest rash.
And if you want to email me too, I can have my front desk call her if you have like a phone number for her. If she's in the system, we can find her very easily. N. Burkemper. The number two.
Everybody.
The number two. Oh, really? Yeah.
So I'll send you the information. I'll call her today. So everyone knows.
Yeah. How far along is she?
It started about